Hello, my name is Rob Maronis, and I'm the Phoenix Area Indian Health Services Injury Prevention Program Manager, or IHS. IHS is part of the U.S. Department of Health and Human Services here in the U.S. Today, like to talk just a little bit about how we address the opioid epidemic using prevention strategies in the home environment here in some of our communities in Arizona, Nevada, and Utah. Before I get started, I should probably talk a little bit about our structure. Again, IHS is one of 12 agencies within the U.S. Department of Health and Human Services. You can see on the slide a few recognizable agencies like the CDC, ATSDR, FDA, HRSA, and of course us here at IHS. Our mission at IHS is simply to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level we possibly can. We have a vision, and that is of one of healthy communities and quality healthcare systems through strong partnerships and culturally responsive practices. Our service population is almost 2.6 million American Indians and Alaska Natives who belong to roughly 574 federally recognized tribes across 37 states here in the U.S. The Phoenix area is actually one of 12 areas or regions, if you will, within IHS. Our service population, as you can see on the map to the right, includes all of the tribes in Nevada, all of them in Utah, most of them in Arizona, and just a few on that western edge of California. We are fortunate enough to actually have four dedicated injury prevention staff to help us work on the injury prevention problems that our communities see. And we're housed within the Division of Environmental Health Services. We're the 16 field-based environmental health staff that help us work on these injury prevention initiatives. So the Division of Environmental Health Services is, what you might think of as a public health department. So they're constantly out in the communities, working with the community members. So we're naturally a good fit to house our program within theirs. So today I'll talk about a little bit about how we assess, our problems to try to figure out what's happening in the communities. I'll talk a little bit about how we plan our interventions and then the importance of developing partnerships to get our work done. So this is a depiction of the public health approach. We use it for all of our programs in injury prevention. We didn't invent it. It was actually created by CDC to help address the issue of communicable diseases or infectious diseases. But really, you can apply the public health approach to just about any program or problem you have, including injury prevention. It's a four-step, easy to understand approach, and it starts with trying to figure out what the problem is or defining the problem. And we do that by conducting surveillance. We gather our data and our information to see what's going on in our communities. But once we know, what the problem is or what type of injury problem is occurring, we really need to know what's causing it. And that, the causes we refer to as risk factors or contributors. And that's the who's and the what's and the where's and how's and the when's. All those things about the injury incident that contributes to, our injury problem. And so once we figure out the problem, what's causing it, it's time to identify a solution. And we need to find what will prevent the problem or what works, to address this problem. There's lots of information on the web. There's lots of programs and projects out there that likely have similar injury problems that you may see. So it's good to start there and see what has been done to address a problem that you might be seeing. So once we find a potential solution, it's time to kind of shape it, mold it till it works. So it's accepted in our communities. And then we implement it and we evaluate it to see if it's working. And that's the prevention step, or that last step of the public health approach. So this is another way of laying out the public health approach. It's a more circular pattern, more, it shows that the approach or the process really doesn't end until the problem is solved. We'll continuously keep going through these phases until we've got a handle on our problem. So our assessment process, again, we start by assessing the problem to see, what exactly is happening in our communities, and we do that through surveillance data. So we're trying to find out what's the problem and what's contributing to it, or what's leading up to that problem. Once we know, those details, then we go and we look for interventions. We might conduct literature reviews. We might look in scientific journals to see what other practitioners around the country or even around the world have done to address a problem that we might be seeing. We are looking first and foremost for these types of interventions that are called evidence-based or effective strategies. And those are simply projects or programs or strategies that have been tried and proven to work on the problem that we're having. So for us, we don't like to reinvent the wheel. We first try to see, okay, what are the effective strategies? What works out there to address our problem, and we start from there. And hopefully, we can come up with some solutions to help us in our communities. It's also important to assess the community that you're working in. It's we have say we've identified the problem and the contributors, and we've got this menu of potential solutions that might work. Well, we want to go to our tribe, our community, talk to the leaders, talk to the potential target audience to ask them the simple question. Hey, this is the problem that we're seeing. These are some of the solutions that we are proposing. Will they work? What do you think? Can you help us shape these into a solution that will be more acceptable in the community? Um, And we do that through interviews, interviewing stakeholders or tribal leaders. We might conduct focus groups amongst the target population or a community-wide survey to get a broader perspective of the community's opinions on what we want to do. It's also important to identify the community's will. Is this something that they want? Is this something that's going to be accepted by them? Or do we need to do a little more work to try to make them comfortable or get them comfortable with the solutions that we're proposing? Um, and then lastly, is their capacity to achieve the goals and objectives of our intervention? Are there enough resources out there for us to be able to operate this program? If not, we likely need to look around and try to find some additional resources before we get started. So the planning phase is equally as critical, and we start our planning phase with what we call a community participative approach. I mentioned on the previous slide, we present some potential solutions and we ask the community, we ask the tribal leaders or program managers, what do they think? Will it work? Can you help us, shape it to make it work? And that allows the community buy-in, the ownership from the community. So it's not just our program, it's their program and really everybody's program. And that really increases the chance for successes of many of these types of programs. And then while we're planning, it's important for us to create a work plan. We always rely heavily on what we call SMART-based goals and objectives. And that really allows us to kind of measure what we want to do. And it asks those questions like who's going to do, what type of task, how are they going to get it done, and when can we expect for them to complete that task? And really using the SMART-based goals and objectives helps us, keeps us on track, and also allows us to evaluate our progress. And speaking of evaluation, evaluation is one of the steps that's commonly left out of some of our injury prevention programs. It's a important process for us to identify, is our plan working? Are we making a difference? Are we reducing these risk factors or contributors that leads to the injury problem that we're seeing? Um, and also the tools, we might develop, a whole host of tools while we're moving through our projects. One that we use on one of our projects, which is the medication lockbox project to address the opioid epidemic, you can see there on the right, and that's a simple data collection form. It's a sign up form for folks who might be interested in participating in the project. So it's important, to develop these tools upfront Equally important to test them before you actually start using them to make sure they make sense. Make sure you don't have to make any changes after you get started. That way you can continuously use the same forms each time. And the partnerships, I mentioned partnerships a few slides back. And every time I give an injury prevention talk, I always make sure that I mention that injury prevention is a team sport. It's critical that you don't try to do it by yourself or one individual. Although your intentions might be great, you might put all the effort that you can in the project, but really you might be selling yourself and your target audience short because you won't be able to have the impacts that you could with a bigger team. Um, so some of the benefits of building these partnerships or these collaborations, you reduce that burden on one individual because keep in mind everyone's busy, everyone has a job. And so you don't want to pile, injury prevention work on top of an already busy schedule. You want to spread it out a little bit. And so individuals or programs, um, the more you can get to the table, the better. Hopefully you can bring some folks that have different expertise or different disciplines. I mentioned the medication lockbox project we worked on. We had to work with a lot of pharmacists. I'm not a pharmacist by training, so that the information and the bits that they brought to the project were valuable and helped us achieve the successes that we saw. Um, and again, having more people, more exposure, more expertise will increase your potential impacts of your projects and interventions. So build your team. So I talked a little bit about the opioid epidemic. Back prior to COVID, we were starting to see a pretty significant spike in opioid related deaths and hospitalizations. This is just a few of the statistics. Opioids each day were killing hundreds of Americans across the country. The financial or economic burden was really spiraling out of control. Each year, we were spending almost $80 billion to address this crisis, and that's an unforeseen expenditure for lots of hospital budgets. Here in Arizona, where I'm at, um, our opioid related deaths increased 74% since 2012, and that's 2012 to roughly 2016. So 74%. That is a huge increase. In 2016 alone, we saw 1,500 drug overdose deaths in Arizona, and over half of those were contributed to opioids. Unfortunately, our American Indian Alaska Native populations here in Arizona were not immune. Those deaths and hospitalizations and emergency department visits increased 310% from 2008 to 2016. So in 2008, we were seeing about 235 cases. By the time we looked at the 2016 data, it was up to 965 cases. So I mentioned, in Arizona, we saw a 74% increase for all Arizonans. For our Native American population, that's a 310% increase. So that's a huge disparity in the two populations within Arizona. So that really for us, represented a call to action. We saw the problem. We had to figure out what we can do about it. Where was our lane, or where were some of the things that we could do to try to make a dent in this problem? So back to our public health approach. And again, we use this on all of our injury prevention programs. So we decided why not use it for this opioid epidemic? So again, that first step, defining the problem. I mentioned the information on the last slide. I mentioned the 74% increase in Arizona. And then in 2016, over 1,500 drug overdoses, and half of those were from opioids. So then we started to look at some of the risk factors, lots of potential contributors or risk factors, but we started to look at them and identify which ones that we could, have a hand in addressing, and so for our program, many times we are in the homes in our communities conducting other environmental health or injury prevention type services. And one of the common observations that we see is the stockpiling of medications. medications stored on the kitchen table or kitchen counter, coffee tables, end tables, nightstands, on top of the refrigerator. Lots of different places. Almost always they were unsecured, which makes them available for folks who aren't intended to take those types of medications. We also interviewed the pharmacies in those communities. And one of the things that they were noticing was an increased early refill requests. And we asked them, okay, what exactly does that mean? And the response was many times when we see a spike in early refill request, it's because they either lost their medications, possibly abusing the medications, or there might be some sort of medication theft involved, one of those three. So that was another kind of telltale sign of some potential contributors to this problem, stockpiling, and then misplaced medications or abused medications. So once we identified, what was contributing to the problems, we came up with some potential solutions. The biggest one was we needed to figure out how can we separate the risk for the opioids or other types of medications from that potential victim or the person that might overdose. Some strategies that were suggested would be to remove all medications from the homes, and we all know that's not a feasible strategy. Another one brought up was we needed to figure out a way to safeguard the medications while they were being stored in the homes. So that right away was one of the potential strategies that we could use. So we engaged the community. We conducted our focus groups again. We asked, some of the program managers or tribal leaders what they thought about these contributors. And then we also hosted a few community-wide surveys. Uh, Once we did all this work, we prepared our program, we launched it, and we evaluated and we monitored it just to see if we were making a difference. So the solution that we were able to identify was storing medications in the home using a medication lockbox, which is a steel box, lockable, hopefully accessible only by the person that's intended to have access to those medications. You can see an example of those in the picture on this slide. There, the top left is one of our teammates demonstrating the use of the box. The top right is an actual installation picture. Um, Bottom left is one of the requirements we had, and this was coming out of our focus groups, a request by the folks that would be using the boxes, was they didn't want to rely on one locking mechanism. So we identified a safe that not only had the digital keypad as a primary method of entry, but also the backup key, just in case the battery did not work or something, or they forgot their code, they could still access their medications with a key. And then that picture on the bottom right is the sort of the completed project, the finished installation of a box. So when we were asking our tribal communities about how to shape this project, we needed to figure out, okay, who is going to participate? Who are we going to test these boxes on? So they helped us come up with these inclusion factors. The first one being age. They wanted their elders or those 50 years and up to be the primary participants. A lot of times the elders are taking many more medications than anyone else. They wanted tribal residents to be participants. They should be prescribed at least one chronic pain medication because that's what we're trying to do is reduce the opioid overdose. And then the last inclusion factor, they needed to agree to follow-up visits. And the follow-up visits is part of our evaluation to find out what, their thoughts about the box, about the processes, and to identify any other concerns that may be raised during the project. So all this culminated with us distributing 55 boxes in 9 tribal communities across 3 different states. And again, it was a community-based team approach. Some of the players on our team were the public health nurses from IHS, community health representatives from the tribes, tribal health departments, health education departments. The senior centers were valuable partners. And then, of course, all the various programs from IHS. So I mentioned the importance of evaluation, and this is our evaluation really in the simple form. We started with an initial survey, or what we call a baseline survey, and really that is to collect the baseline status, if you will, how they're storing their meds, where they're storing their meds, all the little details about what's happening before we gave them the box. And then we followed up and we checked up on them 30 days after that, and then 60 days after the initial survey. And then we wrapped it up after the 60-day survey. And again, those partnerships, the work group that we were able to arrive at, obviously all of the folks from Indian Health Service, public health nursing team. The clinic pharmacy was really valuable at helping us identify that some of the target population, those that were taking prescription medications, more than one, early refill requests. Um, Community health aides were sort of the engine of the program. They were helping us, get into the homes. Police departments, fire departments, senior centers, as you may be aware of, the senior centers are a common gathering point for elders to go and enjoy their meals. And that's typically where we would, find them, talk to them, enlist them, and hear, what they thought about our projects. So, we conducted the baseline again right when we provided the box to the participants. And this is the big four takeaway data points that we brought out of the baseline survey. The top left, we found that 70% of the participants were taking an opioid medication. All of them were prescribed a pain medication, but 70% were taking an opioid-based medication. And in the bottom left, we found that no one was locking up their medications. We saw storage locations throughout the home and in all kinds of accessible locations. In the top right, we found that 40% of those that responded to the survey said they experienced some sort of medication theft, which would probably trigger that early prescription refill that the pharmacists were seeing. And then lastly, 80% of those felt they needed some sort of assistance with their prescriptions, either following the directions or organizing them, storing them, and whatnot. So that was the four take-home messages from the baseline survey. After that, we provided them with the medication lockbox, went back 30 days, checked on them. We did our last check at 60 days to see, what types of changes or impacts we were able to make in the home environment. And I thought they were pretty impressive. The first data point there is the lockbox use. We found that every one of them was using their lockboxes to store their medications. Some of the feedback that we got from them were they felt safe that they were in there. They felt safe that they were consolidated from all these different storage locations in the house. And then they felt that they weren't going to experience any medication theft. Um, the second point there is we found no unlocked medications. That kind of goes with that first point. So, we went from 100% being unlocked or unsecured to 100% locked up and secured, which is really, really a huge success that we saw. And then the third point there, we didn't have anybody raising any safety concerns. And really, there was a couple different types of safety concerns that we were forecasting. One was, perhaps they would feel that they couldn't get into their box if they needed it. Maybe they forgot their code, which was why we selected the safe with two different access methods. If they forgot their code or the battery died, they could use the backup key. So we had no safety concerns. Um, and then the last one, as I mentioned on the last slide, 40% of those folks that we interviewed said they were experienced some sort of lost or stolen meds. None of them experienced that during this project period. Huge success, I believe, coming out of this project. So, that's one of the ways that we were able to at least find our lane or come up with some ways that our program could try to address the opioid epidemic. There's lots of other projects and programs like prescription. They're changing the ways that they prescribe medications in the clinics, the education that's happening in the clinics, all made a difference. But this, from our community perspective, using a community participative approach, was one of the ways that we were able to, what I call, maybe complete the puzzle or fill in some of the gaps of some of the services or activities that we were trying to do to make a difference in this opioid epidemic. So I'd be remiss before if I didn't, talk to you a little bit about the U.S. Public Health Services Commission Corps today. Um, I am a retired Commission Corps officer. You can see on this slide here, we've got over 6,000 active Commission Corps officers that are stationed or assigned at a whole host of federal programs, including the Indian Health Service. And Indian Health Service, we've got them in all 12 of our areas across the country and just about every one of our environmental health offices. So it's a great opportunity. It is a uniform service. You got your Army, Navy, Marine Corps, Air Force, Marines, Space Force even. And then and one of the lesser known services is the U.S. Public Health Service. So if you're interested, if you want to learn more about that, I've got a website, a web link at the bottom, or I'll provide my contact information. I would be happy to talk to you about it or point you in the right direction to someone else. So again, I'd like to thank you for your time today to hear just a little bit about us, the injury prevention program of the Indian Health Service, and how we sort of identified our niche, if you will, our spot to help make a difference in this opioid epidemic. It's a heavy task, a big task, lots of activities going on and lots of different levels, but this was our community-based approach, and we rely heavily on solid public health tools and principles like those effective strategies, using SMART-based objectives, and then building out that injury prevention team to get it done. So that's my contact information. If you'd like to learn more about this or really anything else regarding injury prevention in the Indian Health Service, feel free to reach out to me and I'd be happy to discuss it with you. Thank you and have a great day.